I'd like to start with acknowledging that we're gathered today on the traditional, ancestral, and unceded territories of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. The land and waters of this area have been stewarded by them since time immemorial. And as we recognize the privilege of being able to meet here, I encourage you all to join me in reflecting on our responsibilities towards the earth, its peoples, and our collective mission. Femi, on behalf of the COA membership, thank you for being an admirable leader for our organization. As president, you delivered on your mandate's promise to promote mentorship and increase engagement, particularly of younger members. We saw this through partnership activities with the Canadian Orthopaedic Residents Association and the Canadian Orthopaedic Surgery Student Network, and through COA board training on intergenerational leadership and engagement. We saw you connecting with members and future members at meetings across the country and across social media platforms, raising our organization's profile with your social media savvy. Dr. Ayeni took a lead in revamping the COA communications, and I hope, as you heard earlier today, that you all take time to read the new first issue of the new and improved COA bulletin released at this meeting in its new interactive digital format. I'd also like to say that he did all of this with a grace and thoughtfulness that I know he will carry forward as he joins the President's Council as our international ambassador for the next year. So I hope you will all join me in thanking Femi as well as his colleagues at McMaster and his family for enabling him to share his time and energy with the COA. I'd also like to recognize the exemplary leaders in the COA presidential line with whom I've had the privilege of working over the last few years. I've learned so much from each of you about purposeful and effective leadership. It's a real honor and pleasure to serve our orthopedic community alongside you, and it makes me proud to be part of this dynamic and progressive organization. And of course, we would be able to achieve little if it wasn't for the guidance and hard work of our dynamic and invaluable team at the COA, headed by our CEO, Cynthia Vazina, and Director of Strategic Initiatives, Chelsea Patriquin. They are the string that connects one COA president's initiatives to the next, and the bridge that turns ideas into reality. I'm grateful for having had the good fortune of working with and being mentored by many great leaders over the course of my orthopedic training and practice. There was no possible way I could fit them all in one slide, so if your picture is not here, I hope you still know how much your influence on my life and training has meant to me. Each has had an influence on my leadership style and created opportunity and room for me to grow as a surgeon and as a person. They have all underscored the importance of recognizing that as surgeons, we are seen as leaders whether we want to be or not, but that effective leadership can be achieved in many different ways. I would also like to recognize my department chair at the University of Alberta, and would be remiss if I especially didn't recognize my colleagues at in pediatric orthopedics at the Stollery Children's Hospital in Edmonton for their tremendous and unwavering support. We all know that nobody can do these types of jobs without a team at home to take care of things. Most of all, I want to recognize the love and support that I received from my family. My father Dilsher and my mother Jaswinder instilled in my siblings and I the values of humility and hard work, central to the tenets of our Sikh faith. There are no words for me to express my gratitude to them for the sacrifices they made for our family and for their unconditional and steadfast support, and for giving me the ability to recognize and the faith to recognize that anything is possible. Thank you to my siblings for keeping me grounded and giving me a shoulder to lean on when I've needed that. And thank you to my most beloved nieces and nephews for all the love you give me. Being your puaji is the most valued role that I have in my life, and it brings me joy every single day. When I started medical school, I didn't really know what to expect, as I was the first person in my family to pursue a career in medicine. I knew I would have to work hard and make sacrifices, and I was used to that. But I believed that the long-term gain would warrant any short-term pain. Eventually, I'd be able to help people and make their lives better. I would be intellectually stimulated and have an opportunity to educate future generations. I would be able to make a real impact on the world and would have autonomy. I would make my parents proud, myself happy, serve my community, and while doing so, I could have financial security. So 4 years of medical school didn't seem like such a big deal. And since I determined early on that I needed to become an orthopedic surgeon, I committed myself to 5 additional years for the necessary residency training. The promise of residency seemed so grand. I would get my hands dirty, so to speak, gaining more autonomy while learning from talented surgeons how to do intricate procedures and make decisions that made an immense impact on people's lives. And it was definitely all of those things. But as we all know, orthopedic residency is also very demanding. Mentally, physically, and emotionally, it takes a toll. I was fortunate to have the support of my family, my community of co-residents in the trenches with me, the assurance that residency would only last 5 years, and the belief that life would be better afterwards. Those were the things that got me through the years of 1 in 2 and 1 in 3 call with 36-hour shifts producing a state of chronic and persistent sleep deprivation and missing out on many important family events, not to mention the threat of the high-stakes Royal College examination looming in front of me. As expected, though, life did improve after residency. During my fellowships, I became reacquainted with what it felt like to not be sleep deprived. I pursued my passion for pediatric orthopedics while working with people with the same calling, people who believed in me and gave me independence, and people who challenged me to question conventional thinking and to think bigger and broader. So when I finally entered independent clinical practice, it was with a sense of liberation, excitement, and strength. I joined a great group of surgeons that included some of my mentors. They fostered collaboration and supported my endeavors to push the limits to improve patient care. I built my practice and loved that I was finally getting to fulfill my life's calling. Sure, I still had to do call, but that was all right because emergent surgeries help people. And there was some administrative load that I wasn't necessarily prepared for, but that is all part and parcel of running a practice. And then there were those days in the OR where my responsibilities of being an educator were battling with efficiency and the threat of having a case canceled and disappointing a patient and their parents. But that's all part of being a professional. Overall, being an orthopedic surgeon was just as rewarding as I had thought it would be. And over the years, my surgical practice flourished, producing burgeoning clinical and surgical wait lists. Concurrently, OR cancellations became increasingly common, particularly in flu and RSV season when inpatient beds became more scarce. Some days, all of my scheduled surgeries were canceled because of a lack of beds, or should I say a lack of nursing staff to take care of those patients in those beds. How did we solve this? Well, it wasn't with an influx of more operative resources or inpatient beds. As orthopedic surgeons do, we put our problem-solving hats on and became innovative, developing new pathways to get surgeries done with fewer hospital beds. We found ways to do cases that previously required an admission to be done instead as day surgeries without compromising patient care. We started to send the walking wounded trauma patients home while they waited for trauma time to get their broken bones fixed rather than waiting in a hospital bed. And these measures did help. But the wait lists continued to grow. Patients continued to suffer and get worse while they waited sometimes 1 to 2 years for surgery, and especially inordinate delay when we're talking about a pediatric practice. And remember, despite the fact that we don't control the resources required for the operative management of our patients, we are still held responsible by regulatory authorities and patients themselves for their well-being while they languish on our wait lists. Talk about stress and a serious hit to professional fulfillment. By this time, the COA and my own ABC fellowship group had each conducted studies looking at well-being amongst orthopedic surgeons in Canada. And the news was not good, with more than half of attending screening positive for distress or burnout, and Canadian surgeons faring generally worse than our counterparts in other carousel nations. In Alberta, the powers that be decided that this was a great time to implement a province-wide EMR. Predictably, the rollout caused decreases in clinic efficiency, further decreases in OR throughput, a marked and persistent increase in administrative burden on clinicians, which of course remained unsupported and unpaid, and there was no extra help for managing existing patient loads. It underscored a progressive loss of autonomy and caused frustration and increased discontent amongst hospital and medical staff. So much so that many decided to relocate or retire early to avoid the hassles associated with the EMR. Their departures left huge gaps in team-based care and more stress for those of us who stuck it out. And then the COVID-19 pandemic occurred, resulting in an almost complete shutdown of the operating rooms and minimal access to clinics. As we all know, the pandemic caused a significant amount of additional work-related stress, revolving around risk to personal and family health from potential exposures in hospital, risk to patient well-being from delayed treatments and bureaucratic directives preventing the treatment of out-of-province patients, and financial pressures from decreased clinical activity. Short staffing who became the routine due to pandemic-related absences, retirements, and redeployments. On top of that, continuous masking mandates and restrictions to gatherings in hospitals resulted in prolonged reduction of workplace debriefs, the loss of invaluable hallway conversations, and conversion of educational rounds to virtual formats, reducing our human-to-human connection, a vital part of dealing with workplace stress. The situation was compounded by our provincial government's decision to unilaterally tear up the remuneration contract with doctors. Concerns over financial stability or even viability of some practices ensued and have yet to be resolved. Although funding models vary across the country, issues persist widely. Unlike when this Ipsos poll came out in 2016 suggesting that Canadians trusted their doctors, doctors' voices began to be muted due to misinformation and disinformation campaigns in social and traditional media, driven often by political agendas and secondary gain. These have resulted in effects we continue to face today. Now, not only do resource limitations hamper our ability to care effectively for our patients, but we are faced with a greater administrative burden, and we are being sidelined by policymakers during critical conversations about resource allocation. There continue to be many lingering effects from the pandemic, beyond the change in public sentiment. We continue to have lengthy clinical and surgical wait lists, particularly disadvantaging patients needing complex surgery or complex post-operative care, anesthesia staff shortages, which restrict the ability to increase capacity, administrative restrictions to scheduling cases, particularly for out-of-province patients. And in many hospitals, the nursing staff is less experienced on a whole due to staff turnover, a problem exacerbated somewhat by the rise of private surgery centers, which can offer staff a better lifestyle. And this is to say nothing of political agendas that are not always well-informed or even in synchrony with our own value of prioritizing the well-being of patients. This is a picture that a colleague took of me in the OR one day between cases, prior to my prospective changing sabbatical. They found it humorous that I was on 2 different phone calls at the same time, and I can appreciate that perspective. My lived reality, though, was that I was trying to answer pages and manage urgent patient consults in the limited time I had between OR cases while my next patient was sitting in front of me being anesthetized in the OR. I was doing what we all do. I was trying to make the most of what is available to us to achieve the best possible outcome for our patients. It's no surprise, though, that reports of physician and surgeon moral injury, distress, and burnout post-COVID have shown a worsening of an already bad situation. And it's high time we go beyond discussing the magnitude of the problem. We need to do something about it. If we don't, the consequences of physician burnout are severe, impacting not only doctors and their families, but also patients and entire health systems. While a single fire extinguisher may be adequate to manage a fire in a waste paper basket, we would never consider it enough to successfully manage a burning building. Similarly, in the current healthcare environment, telling surgeons to manage their well-being with things like meditation, exercise, connection to nature, and more frequent vacations naively and unfairly puts the burden of this problem on individuals when the evidence has already shown that we are generally resilient people, which we already knew, because it's not easy to become an orthopedic surgeon. The real problems go well beyond the individual and require a larger scale approach, addressing the institutions we work in. Don't get me wrong, all of these things will help personal well-being, but alone, they aren't going to address the problems we are facing in healthcare today. If we continue to work in the same toxic culture, unsupportive environments, and broken systems exacerbated by extreme and turbulent political agendas, the problem will only continue to grow. We cannot continue to sacrifice our well-being by providing band-aid solutions which allow broken systems to persist at our and our patients' expense. Surgeons, our families, our patients, and indeed our communities will all suffer as a result. For this reason, the COA is prioritizing an agenda of awareness, advocacy, and education to facilitate effective policy changes that reduce unnecessary burdens on orthopedic surgeons in Canada, thereby enabling us to provide better care and achieve better outcomes for our patients, yielding a more efficient healthcare system in the process. Together, we will create resources and drive initiatives to create a stronger and more resilient orthopedic community through advocacy for change and empower surgeons to do the same in their communities. It's time that we take this beyond discussing and managing the magnitude of the problem. We need to stop doing surveys that tell us how badly we're doing and start finding solutions. It's vital that we focus on things that address the institutional problems, because those are the ones that are causing us the things that will be the things that resolve our issues. We need to move on from the idea that how things have been done traditionally is the best way for them to be done in the future. Times have changed, people have changed, the system has changed, and so must our strategies. We need to take care of each other and ourselves as much as we take care of our patients, because people are our most valuable resource. And healthy surgeons produce better patient outcomes. This requires strengthening our orthopedic community through participation and engagement, and valuing our time so that others value it too. When we give our time and energy to something, we're saying that what we are doing matters. For myself, this means, as I'm sure it does to all of you, putting my time towards things that are in line with my values as a surgeon and as a human being, and in things that I believe will make a difference. It makes me wary of administrative demands for my time, where administrators are setting the agenda and getting paid for their time, but surgeons are there on a volunteer basis, and their presence is seen as support of those agendas, even though they do not have a voice and our issues and concerns are not addressed. It also means that we need to be wary of the extent of personal sacrifice we make to prop up a failing system. Resilient systems readily accept failure in order to find new and better ways of doing things with the least loss possible. Yet in the healthcare system, surgeons are constantly playing the role of the little Dutch boy, placing our fingers in the holes of the system to try to prevent patient suffering, whether this be carrying the burden of long wait lists, overextending ourselves by doing after-hours surgeries for non-emergent cases simply due to a lack of resources, or conducting significantly overbooked clinics. I don't know about you, but I'm tired of all of that. We are distracted by misguided administrative directives that ask us to focus on improving statistics, which are being misused to justify a lack of effective and necessary reform. Instead, we should put our energy to doing things that actually make a difference, because what we're doing now will only lead to catastrophic failure at some point. Effective advocacy for change means going forward with a united voice. While orthopedic subspecialty societies serve a very important role in advancing science and creating communities for discourse and mentorship, they can threaten our ability to advocate effectively for change if it means they divide us. Strength is in numbers and unity. If we want to have a voice that is heard, where decisions are being made, we need to come together with one strong voice. And we need to ensure that that voice is heard and that the problems we see every day are highlighted to policy and decision makers, along with viable solutions that prioritize our and our patients' well-being. To be effective, we need to understand the priorities of bureaucrats and politicians and frame our solutions in terms they will also support. This requires developing solutions that work for us, our patients, and our health systems. Our advocacy will be informed by evidence, engaged COA members, and collaboration with strategic partners. We will identify priorities and strategies for effective change. In fact, we have already begun this process, and I encourage you all to review the COA's statement on surgeon health and wellness in our new strategic plan. As a collective, nobody understands our practices and our patients better than we do. We have a lot of the solutions to the problems we are facing in delivering effective and efficient orthopedic care to patients in Canada. It is vital that we come together, share our ideas, and implement viable solutions with a united and trusted voice that we make sure is heard. The consequences of not doing so are too great. There is no shortage of potential measures that can work towards improving the resilience of our health systems while improving surgeon well-being. I know we can and will make a difference, and I'm excited to work together on this initiative with all of you. I hope you are too.